name in the chat, or you can put your mic on and speak if you want to, all the different types of contraception that you can think of. RUD, yep. Combined oral contraceptive pill, IUS. Condoms, yep. Implant. Okay, so these are all the ones that I could think of. So female and male condoms, natural family planning, which we're not going to touch on today. I don't think you really need to know it in much detail for UCL, but this is things like tracking your temperature and tracking like discharge changes and that kind of thing. And there's not much, there's some scientific evidence behind how much it works, but not that much. So I'd say probably don't need to worry about that. It's not something you will get tested on. Then combined oral contraceptive pill, combined transdermal patch, vaginal ring, progesterone-only pill, progesterone-only implant, progesterone injections, intrauterine device, intrauterine system, emergency contraception, and then female and male sterilisation. I'm not going to touch on either of those in this lecture either, but what you should probably know is female sterilisation is basically not reversible, whereas male sterilisation is more easy to reverse. So it's not always going to be able to, you're not always going to be able to reverse it, but you will have a much higher chance of reversing it than female, which they basically say is irreversible. So just to note. So the first thing we're going to do is go over the barrier methods. So male condoms. So they're rolled over the penis and they collect semen, and they basically prevent the sperm from entering into the vagina. Very basic. So the advantages is that they protect against STIs, which is why you're advised to tell patients to use condoms along with every other method of protection, contraception, because they're the only one that really they're the only one that protect against STIs. So especially with casual partners, you're advised to tell patients to use condoms too. They're non-hormonal, which for some couples is what they want. They only need to be used immediately before intercourse, and then they're the only contraceptive male that is controlled by males, which might be desirable for some people as well. And then disadvantages that they may tear or not be used every time. They can reduce sensitivity and arousal, and then they're contraindicated in latex allergies as well. So female condoms, these basically it's a tube, and one end which is closed goes into the vagina, and the other end is open and sits outside the vagina, and the idea is that it stops basically the sperm entering the cervix. So again, the advantages are that it protects against STIs. It's also non-hormonal, so it doesn't have any of the contraindications that all the hormonal methods have that we're going to go on to. It's less likely to tear than the male condom, and it can be inserted before intercourse, which might be beneficial for some people. I don't know. Disadvantage is it can become dislodged, or the penis can go between the condom and the wall of the vagina, which obviously will not work. It may not be used every time, and then it can be noisy or uncomfortable during intercourse. So the combined method is progesterone and estrogen. So the combined methods make up most of the different types of contraception. So basically they contain estrogen and progesterone. So together, the estrogen and progesterone create a level that is constantly inhibitory of the HPG axis, which basically means that the gonatrophs, so LH and FSH, are not released, which then means that it prevents the LH surge, and if there's no LH surge, you don't get any ovulation. So effectively, they prevent ovulation. And then the progesterone also prevents implantation by causing proliferation of the endometrium. By inhibiting proliferation of the endometrium. So the endometrium, which lines the uterus, is really thin, so a fertilized egg cannot implant into it. And then it also thickens the cervical mucus, which then prevents the passage of sperm. So that's an element that the progesterone does. And Anusha's just said that counselling contraception is likely to come from an OSCE station. So it is basically what you need to remember is, well, we'll come back to that at the end, actually. We'll go over that later. But if you have any questions as we go along, just pop them in the chat. Okay, so the most common method that people probably know about is the combined oral contraceptive pill, which is basically a pill that contains progesterone and estrogen. And it's the most common type is monophasic, which basically means each pill contains the same amount of progesterone and estrogen. And you can get like triphasic and biphasic, where it differs, but I wouldn't worry so much about those because they're not, like, you wouldn't need to know about them. They're more specialist use. So yeah, each pill contains the same amount of progesterone and estrogen. So you take the pill once daily for 21 days, and then you have a 7-day break. During that break, you get withdrawal bleeding. So it's not actually a period, it's withdrawal bleeding from not taking the pill, if that makes sense. So you have a 12-hour window to take it in. If you take it outside this 12-hour window, it's deemed as late. So what you should do is, if you start the pill within the first 5 days of your cycle, you can use it without extra precaution. So basically, if you start the pill while the woman is having her period, then you don't need to use any extra protection. If you start it after day 5, you need to use condoms for 7 days. So missed pill rules. This is probably the most confusing thing about contraception. So if anyone doesn't get it, please let me know and I'll try and go over it again. So if it's less than 24 hours late, there's no issue. You just need to take that pill as soon as possible, even if that means you take 2 pills at the same time. That doesn't matter. But if it's one pill is less than 24 hours late, you just take it as soon as possible and there's no issue. If one pill is between 24 and 48 hours late, you take that pill as soon as possible, and then you take the remaining pills at the usual time. So that could mean you take, as I said, 2 pills at the same time, which is not an issue as long as you take them. And then, so more than 2 pills, so 2 or more pills, more than 48 hours late, this is where the issues arise. So you need to take the most recent pill as soon as possible, and then take the next pill at the usual time, and then you need to use condoms for 7 days. And then, if you miss the pill in your first week of the packet, so as I said, you take it for 21 days, so the first 7 days, then 7 to 14, and then 14 to 21. I will come on to that question in a minute, I've seen it. So if you miss the pill in the 2 pills in the first week, you will need EC, which is emergency contraception, if you had sex in the pill-free interval or during the first week. If you missed 2 pills in the second week, then no emergency contraception is needed, but you need to make sure that you take the last week, so the last 7 days of your pill properly. You have to take all 7 of them at the right time. If not, then they will need emergency contraception. And then if you miss the pill in the last week, then you don't need any emergency contraception, but you omit the pill-free interval, which basically means you take 2 packets back to back. So you don't take a week off. As soon as you've taken your 21th pill, you start a new packet straight away and you don't have any breaks. Does that make sense? This is, as I said, the most confusing thing that I thought about contraception. If there are any questions, pop them in the chat. So someone has just asked, could I clarify that the first day of the cycle is the first day of your period? Yeah. So if you ask someone about the first day of your cycle counts as the first day of your period, so day 1 is the first day that you bleed. So when you ask someone about their last period, you want to know the first date of their last period. So you have to specify that, because most women, if you say when was your last period, they'll tell you when it finished, and you want to know when it started, not when it finished. Okay. Right. So you can't take more than 2 pills at the same time. You can only take 2 at the same. So someone just asked, so can you end up taking more than 2 pills at the same time? No. So if you miss 4 pills, for example, you take the most recent pill that you missed. So you would only take the pill for day 4, for example, and then you take the pill for day 5. You don't take 1, 2, 3, 4, and 5. So you only take 2. You forget about all the other ones and only take the most recent one. Does that make sense? Okay, so other methods. These you probably don't need to know about in as much detail. In my opinion, they're a bit random, and I've never really ever seen them used in practice, but people do use them. So the first one is a transdermal patch, which is basically a patch that's either stuck onto the upper arm, the abdomen, the bum, or the back, and it basically just delivers progesterone and estrogen through the skin into the circulation. And then you change the patch every 7 days for 21 days. So it's a bit like the pill. You have it on for 7 days, then you have a new one on for 7 days, then a new one on for 7 days, and then you have 7 days with no patch, which is basically where you get your breakthrough bleeding. And the other method is a vaginal ring, which is basically a plastic ring that goes in the vagina. It's there for 21 days, and then you remove it for 7 days, and then you put a new one in. And you can remove it briefly to clean it during those 21 days, but you have to put it in pretty quickly afterwards. Okay, so the advantages. So they're highly effective if taken correctly. So you have to remember to take all your pills. If you're not going to take them, they will not be effective. So sex isn't interrupted because you just take it at the same time every day, but that doesn't rely on when you're having sex. So menses become regular, lighter, and less painful. So some women who have heavy periods or painful periods may go on to one of these methods, particularly the combined oral contraceptive pill, to help reduce their period pain and make their periods lighter. And then you can have some sort of control over the time of menses. So you can take pill packets back to back. So you can omit the pill-free interval and take, for example, 2 or 3 packets back to back, and then you won't have any bleeding if you do that. So in that sense, you have control over menses. This is something that doctors would normally tell patients to do. You shouldn't just let the patient go and do it on their own. But for example, if a woman gets really, really bad period cramps, she might take 3 packets back to back and then only have a breakthrough bleeding after every 3 packets rather than after every packet. It improves acne, so quite common for women. Anoush, did you have a question? Sorry, you put your hand up. No? It improves acne, so some women with bad acne will go onto it, the pill for their acne, or they might use it in conjunction with other things. It also reduces the risk of ovarian, endometrial, and colorectal cancer. That is something to remember because it could be an SVA, because as we go through, you'll see that the different methods of contraception all prevent against or reduce the risk of different cancers. So you need to make sure you know which one does which. And then fertility returns pretty quickly after stopping. Disadvantages are it's got no protection against STI. So as I said before, you might advise a patient to use it in conjunction with using condoms. It's user dependent. So if you forget to take your pills, it will not work. It can cause headaches and migraines, mood changes. It can cause nausea and bloating. You can get unexpected bleeding, so like spotting, which is bleeding basically within the 21 days that you're taking it. It can increase your blood pressure, which is why every woman who has the contraceptive pill, normally, I think it's the NICE guidelines is that you can only issue 6 to 12 months at a time, and you can't reissue more than 12 months until the woman's had her blood pressure checked, because it can raise blood pressure. So that's why women will have to go and get their blood pressure checked before they get more pill. It can also cause breast enlargement, and then it increases the risk of VTs, MIs, and then breast and cervical cancer.
I was just going to mention one other thing. So, like, the way to think about, like, how certain drugs change the risk of cancer is people on the pill often ovulate fewer times. If you've got fewer follicles during your entire life, that's less risk of inflammation, which means there's less risk of ovarian cancer. Like, so if you can think of ovarian cancer in terms of how many times are they going to ovulate over their life, that will give you what changes your risk for it. I don't know whether that makes sense.
And then a similar thing with breast cancer. If you're having less ovulations, no, it's a reverse. It's because of the estrogen that increases your risk of breast cancer, basically. So someone's just asked, with the patch in the ring, who replaces it? And could you repeat the 3-month thing? So with the patch in the ring, the patches, I think it's like when you go to the pharmacy and you get your pill prescription, you can pick up the patches and you can replace them yourself, because most of the time they're accessible for you to replace, and you just peel it off and stick a new one on. The rings, I think to start with, you'll have to go and get it done by someone else. And then you can learn to do it yourself. But I don't know how the prescription works with that. It's not something you would need to know. You would just need to know about the pill, for example. But with all of those, you do need your blood pressure checked before you get them reissued. Okay, so the 3-month thing. Some types of pill, well, all types of pill, you can, rather than having 21 days of taking the pill and then 7 days of not taking the pill, you can do 21 days of taking the pill and then start a new packet and do 21 days of taking the pill and then do another set of 21 days. So you took 3 lots of 20 or 3 packets next to each other with no 7-day breaks in between. So basically when you do that, you take the 3 packets back to back. It basically means you don't get any breakthrough bleeding. And sometimes the breakthrough bleeding can be really painful for women and they can bleed quite a lot. So if you experience this, the GP may advise you to take away the gaps and only have 1 gap every 3 months rather than 1 gap every month, so that you basically bleed less. Does that make sense? Let me know if it doesn't. Okay. Feel free to keep asking more questions. Right, so absolute contraindications. So these are some you need to know about, but I will link a website in a second that you should look at. So having a BMI over 30, being less than 6 weeks postpartum. So absolute means that you cannot give it at all. So you can give it to a woman if she's like 8 weeks postpartum, but you need to be careful. If you smoke and you're over the age of 35, if you have a history of migraines with auras, if someone has a history of migraines without auras, you can still prescribe it, but you have to be careful. So most GPs probably won't even prescribe it if someone has a history of migraines without auras, just because they don't want it, like it's just safer not to, but you can. If someone has hypertension, obviously it causes hypertension, so if you have a personal history or a family history of VTE in someone less than 45 years old, because it increases your risk. So if you already have a family history with an increased risk, that's dangerous. If you're having prolonged immobility or due to surgery or disability, as again, because of the VTE risk, if you have ischemic heart disease or valvular disease, and if you have breast cancer. So what I would all advise you to do is check out this website here, which basically has like a PDF table thing of all the contraindications for all the different types of contraception. So they're ranked 1, 2, 3, and 4. So 1 means that you can give it no issues. 2 means that you can give it but be careful. 3 means that you probably shouldn't give it. 3 means that you probably shouldn't give it, but you can if the patient like really wants it or there's nothing else suitable. And 4 means that it's an absolute contraindication and that you can't give it at all. So for example, the 4s would be things like someone smokes 10 cigarettes a day and is over the age of 35, or they are 4 weeks postpartum. Does that make sense? Okay, so what do people know about the mini pill or the progesterone-only pill? Anyone know anything about the mini pill? I don't think it's as widely used as the combined pill. So someone said, does it increase the risk of spotting compared to the combined oral contraceptive pill? It can do, yeah, especially at the start. We'll come on to that in a minute, but especially at the start, you are more likely to get spotting than you are with the combined pill, but you can get it with both. But with the mini pill, you are at an increased risk. Anyone know anything else? Does anyone know who the mini pill is good to give to? So basically, the mini pill is good to give to all of these people. All of these people who you can't give the combined pill to, you would put them on the mini pill. So basically, it works primarily by thickening the cervical mucus, which we said before prevents the entry of sperm. And then it kind of also does, it also prevents implantation by thinning the endometrial lining. And then, oh, I forgot to say at the start, there are 2 types of mini pill. If you look, there's a traditional mini pill and then a digesterol mini pill, which is like a newer type of progesterone-only pill. And the digesterol pills also inhibit ovulation, but they're the only type that do. The traditional ones do not. And because of the window, which I'll go on to a second, more and more GPs are starting to prescribe the digesterol pills. So you can start taking it the first 5 days of the cycle without extra precaution. So like I said before, if you give it while someone's having their period, you can basically start it fine. If you start it after that, you need to use condoms for 2 days. This is the only type of contraception that is for 2 days. All the other ones are for 7 days. So make sure you remember that fact. So the progesterone is for 2 days. And then you take the pill continuously with no break. So unlike with the combined pill where you get bleeding, you don't get any breakthrough bleeding because you just take it back to back. So the traditional one has a 3-hour window. After 3 hours, it's late. And the digesterol one has a 12-hour window. So like I said before, GPs prefer it because it's got more leeway to not be late. So if you miss the pill, you need to take the pill ASAP, and then you need to take the next pill as normal, and then use condoms for 2 days. And then emergency contraception is needed if you had unprotected sex within 2 days of the missed pill. So like 2 days before or 2 days after if you didn't already use condoms. Any questions about that? Okay, the implant. Anyone know anything about the implant? So the implant is deemed to be the most effective method of contraception of all of them. So it is a long-acting reversible contraception, and it is the most effective method. It basically is a small tube that goes into, let me turn my camera on. It's a small tube that basically goes into the upper arm. So you should ask the patient which arm is their non-dominant arm, and it goes into the non-dominant arm around like this sort of area. And it's like a little tube about this big, and they make a small kind of incision, and then they basically just slide it in effectively. And it sits there and releases subdermal progesterone. Right, before I continue, we have another question about what you do when you miss a pill. So if I miss day 4 of my pill on day 5, do I take yes? So if you miss day 4 of your pill, on day 5, you take day 4 and day 5. So ideally, for example, if you normally take your pill at 3 in the afternoon and you remember at 10 in the morning that you missed your pill from the day before, you take your day 4 pill at 10 in the morning, and then when it gets to 3 in the afternoon, you take your day 5 pill as normal. Does that make sense? But for example, if you missed day 3, day 4, and day 4, and then on day 5 at 10 in the morning you realised you missed both of them, you would only take day 4. You don't take both of them. You only take day 4, and then you take day 5 when you're supposed to. Let me know if that makes sense. As I said, missed pill rules is probably the most confusing thing about contraception. So just like go over it. So the implant prevents ovulation again, and then it also thickens the mucus, which then prevents the entry of sperm, and then prevents implantation by thinning the lining. So as I said, you start it on the first 5 days of your cycle, so basically while you're having your period, you don't need any extra protection. If you start it after that, you need condoms for 7 days, and it lasts 3 years. So after 3 years, you need to go back to the doctor, and they basically like feel your arm to find the implant. Then they make a small incision at the bottom of the implant and effectively like push it out. Okay, someone has asked, why does the implant need 7 days of condoms, but the combined oral contraceptive pill only needs 2 days? And it's to do with how it's absorbed and how it works. So basically, you only need 2 days of the pill to have protection, but to get the same amount of progesterone that is required, you need it to have been in for 7 days. Does that make sense? So it's like when we come on to that's like emergency, like, so for the combined oral pill to actually be effective, you only need 7 days worth. So you could technically do 7 days of taking the pill, then a 7-day break, then 7 days of taking the combined pill, then a 7-day break, because once you've had it for 7 days, the level is high enough to prevent ovulation, which is how it works. So with the progesterone-only pill, to prevent, as basically Anu said, the oral route is better than subcutaneous route. So you get the progesterone required to prevent the ovulation after 2 days with the progesterone-only pill, but you don't get the same effect with the implant. You need more days to get because it releases it every day. The same amount of progesterone is released effectively. So that the idea is for the 3 years, it releases the same amount every day. So it takes 7 days to get up to that amount where it has its effect, if that makes sense. That was not explained very well, I'm sorry. But yeah, basically oral route is better than subcutaneous. And it's also better than IM, which we'll come on to now. So the IM injection is also a long-acting reversible contraception, and it's important to note this is the method of choice in epileptic women. Can anyone think why this might be the method of choice in people with epilepsy? Okay, if no one knows, I'll tell you why. Because basically, so the injection is the method of choice in people with epilepsy, Anish. It's because the basically what happens is the progesterone, the injection basically goes into the circulation. It's absorbed to its IM, and it's absorbed, and the progesterone is basically absorbed into the blood, and then as it just circulates in the blood, and then is like circulates in the blood and it's not broken down properly the same way that the other methods are. So all epileptic drugs interfere with the liver effectively to some degree, and all of these other methods of contraception are also regulated or like broken down by the liver, whereas the progesterone-only injection is not to the same degree, so it still has a significant level even drugs, anti-epileptic drugs. So women who are epileptic are advised to take the injection because there's a more constant level of progesterone, and it doesn't interfere as much, or their medication doesn't interfere as much with it, because the progesterone just circulates, like stays constant in the blood rather than broken down. So yeah. So the most common progesterone injection that you would have heard of is the depot injection, or the depot injection, which is what women will come in for. And basically, it just gives synthetic progesterone, which is released into the circulation. So it's just slowly released into the circulation from the muscle, and therefore it like has its effect that way. So it's not broken down, which is why it's the method of choice in epileptics. So it can either be IM or subcutaneous. So the depot injection is IM, and that is given into like the upper outer quadrant of the bum every 12 weeks. And there's another type which is given IM, and you can like self-inject that into your stomach, but it's not as common. So just know about the depot injection. So this works again by inhibiting ovulation and then thickening the cervical mucus to prevent the passage of sperm, and it also prevents implantation by thinning the lining, but that's not its like main action. So like I said before, if you start it within the first 5 days, you don't get any extra precaution, but after that you need it for 7 days. And this just goes back to the point that it takes 7 days to have a significant level that will be able to significantly thicken the mucus and prevent the ovulation. So they're given every 12 weeks. However, a late injection is after 14 weeks. So the guidelines are that you should tell a woman to come back after 12 weeks just to prevent them being late. So it means that if she can't get an appointment that week, she still has an extra like 2 weeks leeway effectively. So a late injection is after 14 weeks. So if it gets to 14 weeks and you haven't had another injection, you should need to use condoms until your next injection. And if you have an UPSI, which means unprotected sexual intercourse, after week 14, then you need to use emergency contraception. Does that make sense to everyone? Any questions so far? Okay, so then the advantages are that these methods are highly effective, particularly the implant. As I said, that is deemed the most effective method of contraception, and the injection. They're not really user dependent. I mean, the implant sits there for 3 years, so it's like super effective in the sense that for 3 years you don't need to do anything and it's there. That also sex is not interrupted, and then it reduces the risk of endometrial cancer. So the progesterone-only pill also decreases menorrhagia and dysmenorrhea. Does anyone know what those two words mean? So it reduces heavy periods, and not irregular. It's heavy periods and painful periods. So menorrhagia is heavy bleeding, and dysmenorrhea is painful bleeding. So it reduces the incidences of those. And then the pill and the implant, once they're removed, you return to fertility pretty quickly afterwards. Whereas disadvantages, there's no protection against STIs. As I said before, you should always advise people to use condoms with them. Three of them produce an irregular bleeding pattern. So as someone said earlier, the combined oral contraceptive pill, it's very common to get spotting on it, which is basically like bleeding randomly when you're on it. Usually that does settle down, but it can take like a few months to do so. You can also get no periods, or you can get episodes of like prolonged bleeding. So spotting is just like a little bit of blood every now and then, whereas prolonged bleeding is obviously a large episode of bleeding. The implant can cause no periods at all, but it can also cause irregular and heavy periods as well. And then the injection usually can cause, and it's quite common to do at the start when you first start taking it, it will cause persistent erratic bleeding. And this is something to warn women of, because once they've had the injection, it lasts 14 weeks. So you can't just like stop taking it like you can stop, or like take it out like you take out the implant. It's still going to be there for 14 weeks. So you have to warn them that they may get like some very random but quite heavy bleeding. So you need to warn them of that. Then it can cause generic things like mood changes, headaches, breast tenderness. It can cause acne. So if someone's got really bad acne, it's probably not best to give this to them. Then vaginal dryness, bloating. It can increase the risk of breast cancer. And then the injection has some other things you need to be careful of. So it's not rapidly reversible. The average time it takes to reach your pre-injection fertility is 1 year. So if a woman is trying to conceive or not trying to conceive, if a woman is saying to you, oh, I want to start a family soon, but for the next few months I don't want to, don't give her the injection, because that's a terrible idea, because it will take her a year after she's taken it to get back to fertility. It can cause weight gain. So the injection is the only method of contraception that is like scientifically proven to cause weight gain. So you'll hear lots of people say, oh, my pill made me gain weight. There's actually no scientific research to show it, but there's like anecdotal evidence, but no actual research. And then it also causes loss of bone mineral density, particularly with prolonged use. So you have to be careful. You wouldn't advise this in using this long term, and you also wouldn't advise using this in a younger woman, so someone under the age of 18. That's a good point. Does anyone know what contraception you would advise in someone under the age of 18? What would be the best method? Any suggestions? Someone has said barrier method. No, you would say barrier methods, but you would say barrier methods, and you would also want to give them a actual proper form of contraception, if that makes sense. So you'd want to try and give them a long-acting reversible, and the long-acting reversibles are the implant, the injection, and then the coils. So you wouldn't give an injection to a young woman under the age of 18 because of the bone mineral density issues. So that's not advisable. The coils, so you can give those, but it's not advised in the sense that younger women, they may be more difficult to get in, and that can cause a lot of discomfort. So the actual method is that you would advise them to get is the implant. So women under the age of 18, the method of choice is the implant, and that is just because it's a long-acting method. Obviously, if they want to take a pill, you can consider it, but you want to the first line methods are the long-acting reversible contraception methods. So you want to always try and push for those first before you go down the pill and stuff. So in a woman under the age of 18, you would advise them to use barrier contraception and then try and give them the implant. Okay. So the contraindications. This is kind of generic ones. So if there's any liver problems, if they have a history of or current breast cancer, have a stroke, TIA, or heart disease while taking the method of contraception. And then important to note, as I said, for the injection, if someone is wanting to start a family soon, don't give them the injection. Okay, so does anyone know what's the difference between the intrauterine system and the intrauterine device is, without looking at my slide? Intrauterine system versus intrauterine device. Yeah, so the intrauterine system is hormonal, and then the intrauterine device is the copper coil, which is the only method of non-hormonal contraception apart from condoms. So we'll go on to the system first, because that's progesterone only. So basically it is a little plastic frame, effectively, with progesterone reservoir on the stem, and that basically secretes progesterone into the uterus. So obviously the coils, they go into the uterus, so you have to put them through the cervix into the uterus, and they're literally a little T, basically like that, and it goes like this. You put it in, and then it opens up to a T, and then it sits basically in the cervix. No, sorry, in the uterus, which is kind of shaped like an upside down triangle, like this, so it kind of fits in. Sorry if that didn't make any sense. So there are 3 main different types. The Mirena is probably the one that everyone's heard of. It is the most common. Then you can also have the Kylena and the Jadis. So it's important to note that the bigger the coil is, the larger the dose. So the Mirena is the biggest coil. So that has the largest reservoir of progesterone, and it also releases the largest amount of progesterone every day, whereas the Jadis and the Kylina are much smaller, and they release smaller amounts of progesterone because they have a smaller progesterone reservoir. So the smaller ones you're more likely to use in a woman who's never had a child before, because it's more like her cervix is much smaller, so it's easier to get those into the uterus. They last 3 to 5 years. So the Mirena lasts 5 years, and then some of the Jadises last 5 years, some last 3 years, and the Kylinas the same thing. Some last 5, some last 3, but all the Mirenas last 5. So their method of action is they prevent implantation by thinning the lining, and they also thicken cervical mucus. It is really important to note here that they don't prevent ovulation, so they do not stop you ovulating, which we'll come back. Does anyone know what that is? I'll ask you. If it doesn't prevent ovulation, does anyone know what complication you are like at risk of getting, which we worry about? Anyone know? Okay, I'll leave you guys to think while I keep talking. We'll come on to it in a second. So as I said, with all the other ones, if it's inserted in the first 5 days, then you don't need to take any extra precautions. If it's inserted after that, then you need condoms for 7 days. And this is just because the level of progesterone is not high enough for it to have thinned the lining and prevented the thickened. So the other one is the copper coil, which is, as I said, is the last method of long-acting reversible contraception. It is basically a plastic frame, like a T as well, and it's just got like copper basically wrapped around the stem. And this lasts 5 to 10 years, depending on the size. But I think most of them last about 10 years. So this, again, prevents fertilization and implantation. So basically it does this by the copper stimulates an inflammatory reaction in the uterus, which is like the uterus doesn't like. It's like copper toxicity. So the uterus doesn't like the copper present, so it like basically gets inflamed, and that inflammation prevents implantation because nothing can implant when the uterus lining is a bit angry. And then the copper is also toxic to the sperm and the egg, which means there's no fertilization is unsuccessful. So this one, in the idea that it prevents fertilization and it prevents implantation. However, also again, it does not prevent ovulation. So, and as this is really important, this can be fitted at any point during the cycle because it provides immediate contraception. So the copper coil is a type of emergency contraception, which we'll come on to in a minute. Okay, so as I said before, advantages. These are both extremely effective. They sit in your uterus for like 5 years, and you don't have to do anything about it. So they're really effective methods. Fertility returns to normal immediately after stopping. So after taking them out, you go back to normal fertility. So the IUS causes lighter, less painful periods or no periods. So if someone has its first line for women with heavy periods or painful periods, the first line treatment of that is trying to give them a coil. And then the copper coil is non-hormonal, which obviously some women will like. So disadvantages, can anyone, apart from the one person who's already answered my question, anyone else? No? Well, the IUS and the IUD you're at risk of because they don't prevent ovulation. I'll tell you, it's ectopic pregnancies. So, can anyone think of any other complications that you might have with inserting with particularly the insertion of the IUS and the IUD? Any things that might be a problem when you insert them? Oh, okay. Well, we'll go through it. So they don't protect against STIs, for a start. So they increase the relative risk of ectopic pregnancy. So this is important to know. It increases the relative risk, which basically means that the overall risk of an ectopic pregnancy is lower compared to like people without a copper or a progesterone-only coil. However, if pregnancy does occur, it is more likely to be ectopic because there is something sitting in your uterus, which is less likely that it's actually the egg is going to implant in the uterus. So if someone comes in with like a positive pregnancy test and they have a coil, you have to do an ultrasound on them. Does that make sense? The increased relative risk thing. So you have to ultrasound all women who come in with a positive pregnancy test or signs of pregnancy and they have a coil, because you need to make sure that it's not an ectopic, basically. So the copper coil causes heavier, more painful bleeding, which puts some women off. Then the IUS causes unpredictable bleeding. So this is meant to settle down after 3 to 6 months. They say that you'll get random heavy bleeding or spotting or whatever for the first 3 months, and then insertion of both of them. You can get pain and cramping. Obviously, something's going into your uterus through your cervix. You can get expulsion. So sometimes your cervix will not like it, and it will just not your cervix, your uterus will not like it, and it will just kind of literally contract it and push it out. You can get perforation. So you can perforate the uterus when you put it in. This is most commonly going to occur during the insertion. It can occur up to, I think it's a month afterwards, but it's most likely to occur when you insert it, and then you can get infection. So if a woman has a STI already, and you push something through her cervix, through her vagina, through her cervix into her uterus, you can spread the infection. So you can cause pelvic inflammatory disease, basically. I had something else to say, but I can't remember. So no, it doesn't cause any problems long term, because it's literally just localized to the lining of the uterus. So someone's just asked, the copper coil works by causing inflammation. Wouldn't this cause long-term problems? So no, it literally causes inflammation of the endometrium, which is the lining of the uterus. And it just means that when it's very localized and it's not very severe, but it just is enough to mean that an egg cannot implant, basically. And the second as you remove the copper, the reaction kind of stops, the inflammation stops. So it's only only there while the coil is there. If that makes sense, Claudia. Okay, so contraindications, as I said before, infection. If someone's got an infection, you don't want to give them if you want to give them spread the infection up. Current pregnancy, so you can give a coil straight after birth, so within the first 48 hours after birth, or you can give it more than 4 weeks postpartum, but you can't give it between, because apparently it decreases uterine contractility post-birth if you give it between those windows. So research is saying in the first 48 hours it's fine, but after that it will prevent kind of uterine contractility, which is not what you want after giving birth. So structural abnormalities of the uterus, current endometrial or cervical cancer, and then the IUD, so the copper coil, is a copper allergy. Obviously, if someone's allergic to copper, you don't want to stick a copper thing inside their body. And then Wilson's disease, which, as you hopefully all know, is a dysregulation of copper. And then the IUS is liver disease, history of breast cancer, and strokes while using it. So this is the similar things to what you would in the other progesterone methods. Okay, we have a case now. So if you guys, do you want to read the case, or do you want me to read it to you? Okay, so if you guys read it, and if anyone's got any answers of what contraception you would offer her and what you should avoid, just put them in the chat. So she's 36. She's come to the GP inquiring about contraception, and she started a new relationship. She smokes 10 cigarettes a day and has never been on any contraception before, but is keen to avoid pills because she thinks she'll forget to take them. She is hoping to become pregnant soon, although is not ready to start a family yet. Has anyone got any ideas about... So firstly, what can you avoid? Anyone got any ideas about what you should avoid? Why would you want to avoid the combined oral contraceptive pill? And why would you want to avoid the injection? So you want to avoid the combined oral contraceptive pill because she is a smoker above the age of 35. That is correct. You would want to avoid all combined... Yes, because she is a smoker over the age of 35. Why would you want to avoid the injection? Someone's put that. Yeah, you want to avoid the injection as she wants to start a family soon. And then, so anyone got any ideas about what you would offer her? Someone said the IUD. Anything else you could offer? IUD, yeah. Anything else other than the IUD? Implant, yep. Okay, so the important things to note in this are that she is 36 and she smokes 10 cigarettes a day. So obviously, as I said before, that is a contraindication, like an absolute contraindication to the combined oral contraceptive pill. And on that website I told you to look at, that will be classed as a 4. She wants to avoid taking pills. With that in mind, you're unlikely to give her the progesterone-only pill because there are other types of contraception. And as I said, you want to kind of push for the long-acting ones. So in that sense, the long-acting ones are the injection, the implant, and the IUS or IUD. You'd probably want to avoid the injection, as quite a lot of you have noted, because she wants to start a family soon. So you don't want to give her that because it will take at least a year afterwards. So the ones that I thought you'd want to consider are the IUS and the IUD, or the implant. Has anyone got any questions on that? And then the other avoided things that you guys said that you already came up with. So what I would say for your exams is, if a woman's doesn't want a certain method of contraception, so say if someone comes in and they really don't want an IUS or an IUD, you can't force them to have it. So there's no point trying to go down that route, like the better types. You don't want to give it. So if you're doing an auscultation and you, oh yeah, we'll do the auscultation thing now that someone asked about earlier. So if you're doing if it's an auscultation and a woman comes in for contraception, one of the first things that you should do is ask her about what methods of contraception she's used before, and does she have anything in mind. So what methods she's used before. For example, say she said, I had a coil. You could say, okay, do you want that again? If she says, no, I hated it and it perforated my uterus after 4 days, she probably isn't going to want you to give her another one. So it's important to ask what she's already had, because she might say, oh yeah, I had the coil and I loved it. In that case, that would be really easy to try and check there's no contraindications and then give it to her again. So it's important to ask about what they've already had and if they have anything in mind. So for example, if they say, I want to become pregnant soon, so I don't really want to take, I don't want anything that will stop me having that, or I don't really remember to take pills, so I don't really want anything like that, then you know to stay clear of those. So basically, as Anush said, auscultation is all about tailoring the options to the patient's needs and to what the patient wants, and they all will have a general idea about what they want, so you need to make sure you kind of ask them. So with an auscultation, how I would do it is ask them what they've had before and if they have anything in mind. Go through and take their history. So you just take a general history. Are you well? Are you on any regular medication? What's your past medical history? So you want to ask about, have they had any strokes or DVTs? Have they had any cancer before? Do they have any liver problems? You then want to ask about smoking. Do they smoke at all? Drinking's not that important in terms of contraception because it's no contraindications, but smoking obviously is. So then you just take a general history, and then once you've got all the information you need, you go through and say, okay, so having talked to you, I think this and this method would be good for you. Which one of those would you like to hear about any of those in more detail? And then talk them through each method. So you need to tell them how it's given. You need to kind of warn them of some side effects, but hopefully what will happen is you'll say, okay, what about the pill and the combined pill? And they'll say, oh yeah, I like the sound of that. And you can go through and say, okay, this is how you take it. These are the side effects you need to be aware of. This is what you do if you miss it. Does that sound okay to you? And that's how you'd structure, how I would structure an auscultation if you had to prescribe someone or talk to someone about contraception. Does that make sense? We'll go on to emergency contraception in a second and do the same thing when I get to the end of that. Are there any questions about auscultation in that sense? Okay, if you think of any, put them in the chat. So emergency contraception is 11S. One type is the morning after pill, which there are 2 types of. So the first one is levonorgestrel or Levanel. So emergency contraception basically is used to prevent pregnancy following intercourse. So this one is a 1.5 microgram tablet of synthetic progesterone. It can be used within 72 hours or 5 days of unprotected sex, and it delays ovulation 5 to 7 days. And basically it works up until the point of the LH surge, so just before ovulation. So if the ovulation has already occurred, obviously it won't work, which is important to note. So you can start taking hormonal contraception straight away, and it can be used twice in the same cycle. So basically with this one, there are no absolute contraindications. So if you're doing an SBA and this woman's got liver cirrhosis, or she's breastfeeding, or you think something's probably a contraindication, go with this method rather than the other pill, is what I'd say. So you need to double the dose if they have a disease of malabsorption. Can anyone think of a disease of malabsorption? Yeah, celiac disease. So if someone has a history of celiac disease, you'd probably want to double the dose just to be careful. If they have taken a P450 enzyme-inducing drug in the last 28 days, and that's just because it will affect how much is broken down of the Levenel, and you obviously want it to be effective. And then if they have a BMI over 26, or they weigh more than 70 kilograms, and that's just because they have a large body mass index or a larger body mass index. So you need to give them more of the drug to check that it's all going to be absorbed and it's going to be the right amount for them. Okay, the other method is this method, which is called ELA1. Does anyone know how long this is licensed to be used for? Anyone any ideas? Or anyone any ideas which is more effective, the ELA1 or the Levenel? Ooh. Which is more effective of these two? Anyone know? Okay, so this method, the ELA1, is actually deemed slightly more effective. So I think it was if 1,000 people have unprotected, women have unprotected intercourse, I think it was like 80 will become pregnant. If they take ELA1, only 13 will become pregnant. Whereas if they take Levenel, 22 will become pregnant. And then if they use the coil, only 1 will become pregnant. But we'll come back to the coil in a second. Does that make sense? So this is more effective than the ELA1. This is more effective than the Levenel. And it is a 30 microgram tablet, and it's a progesterone receptor modulator. So it's licensed for use 120 hours, so basically 5 days, so slightly longer than the other one. It has the same method of action, so it delays ovulation. You can start hormonal contraception within 5 days. So this is different because the other one you can start it straight away. And it's only recently, I think it was a few months ago, if that's right, Anoush, or maybe at the start of the year. But very recently it's been licensed for use twice in the same cycle. So before you could only use it once, but now you can use it twice in the same cycle. So contraindications, it has loads. These are just a few of them. So as I said, if you're doing an SBA and a woman comes in and you think she's got something that probably is a contraindication, go with the other one. As I said, it's got no absolute contraindications, whereas ELA1 has loads. Okay, so the caveats to these are they don't work if you've already ovulated. So if a woman has already ovulated, it's not going to do anything and she will still be at risk of becoming pregnant. When you give the morning after pill, you need to kind of discuss with the woman long-acting contraception and long-term methods and try and push for those, because it will be better to use than repeated morning after. Women are not supposed to rely on repeated morning after pill methods. So the side effects are things like headaches, nausea, dizziness, abdominal pain, fatigue, breast tenderness. So if a woman does vomit within 2 or 3 hours of taking the pill, it's highly likely that she won't have absorbed enough for it to have an effect. So you need to tell them they need to come back if that's the case. So periods usually start within 7 days of expected time. If it's more than 1 week late, you need to do a pregnancy test, but in 3 weeks. Does anyone know why you have to wait 3 weeks? Any ideas? Yeah, so you have to wait for HCG levels to go up high enough for actually to be registered. So it takes about 3 weeks. So if a woman comes in and saying, oh, I haven't had my period and I took the pills 10 days ago, you need to tell her to wait 3 weeks from the unprotected sex to take the pregnancy test. Okay, so we're nearly done. So the copper coil is also a method of emergency contraception. It is the most effective method, so it's more effective than both of the morning after pills, so it should be offered first line. And as I said before, it prevents fertilization and implantation. So this is also where it gets a little bit confusing. So it's licensed for use within 5 days after unprotected sex, if that's the only unprotected sex in the cycle. So for example, if someone had unprotected sex on day 8, you could give it up to day 13, which is 5 days later. If they had unprotected sex on day 19, you could give it up to day 24. Does that make sense? And then you could also give it within 5 days of the earliest possible ovulation. So this basically means the earliest possible ovulation is 14 days before the end of a cycle. So if a woman has a 28-day cycle, the earliest possible ovulation is day 14. Does that make sense? So I'll stop saying that, but just write in the chat if you don't get it. So is the earliest possible ovulation is day 14. So it's 5 days within the earliest possible ovulation. So if she had a 28-day cycle, her ovulation date would be 14. So you can give it up to day 19 using this rule. If her cycle was 26 days long, the earliest possible ovulation would be 12 days. So you could give it up to day 17. Yeah, that's fine. Yeah, 17. Sorry, my maths isn't very good. Mental maths, up to day 17. So you basically pick either of those rules that works for the woman. Sometimes both of them might work, but if one doesn't work, it's hopeful that the other one will work, and therefore you will be able to give the copper coil as like the first line option to hopefully all women. So it lasts 5 to 10 years, but if a woman doesn't want it in that long, you can remove it, but you have to wait till her next period. So she has to have had the period for you to remove it. You can't just remove it like 2 days later. They need to have bled before you can remove it. Okay, last little bit. So we have a case.
Sorry, I was just going to say they love catching you out on. They give you random period lengths, random cycle lengths, and then they ask you, and everyone just assumes 28 days. So make sure you read the question properly.
Okay, so here, Miss Smith comes to see you wanting emergency contraception. She has not taken any regular contraception and had unprotected sexual intercourse 8 days ago, but has only found out that the condom split. Her menstrual cycle is regular at 26 days, and she is currently on day 16 of her cycle. So, does she need emergency contraception? If so, what can you give her, and why? Pop your answers in the chat, please, people.
Yes, I finally made it home. I left at 5:45.
That's pretty sad. My GP is like a 15-minute drive from my house. It's great. Okay, any ideas? Okay, Claudia, yeah, that's a very good question. So, hold on, we'll do the case and I'll come back to the question, if that's okay. So, anyone any ideas about what emergency contraception you would give in this instance?
And Claudia went for copper coil, which is always a good shout.
Yeah. So, in this case, the important things to know are that she had unprotected sex 8 days ago, which means that you can't give her the either of the morning after pills because they're warranted for 5 days or for 3 days. So that's already way out. And then you could give her the copper coil because she had sex 8 days ago. So her ovulation date is basically as I said, the cycle length minus 14. So her ovulation date is day 12. So you can give it for 5 days within the earliest ovulation, which is day 17. As I said earlier, if we go back to this. So 5 days within the earliest possible ovulation, and she had sex on day 8. Yeah, day 8, and she's now on. No, she didn't. Yeah, 8 days ago. So she had sex. She's now. You can now give it because the cutoff point would be day 17, and she's on day 16, so that's fine. It's not 5 days within the last unprotected sex because she had it 8 days ago and she's only come in now. So you couldn't give it under this rule, but you can give it under the within 5 days of the earliest possible ovulation. So that is an important thing to know in terms of when you can give each contraception and for why. So Claudia's also asked, so with the risk of ectopic pregnancy being increased if you decide to use this as an emergency contraception? I don't actually know. Anush, do you know? I feel like it can't be increased because...
So I think... That's a good question. I don't know. I mean, I was trying to figure it out.
I think the risk of ectopics with the copper coil is less than the risk with the risk with the progesterone only ones.
Yeah, I think so too.
So the copper coil actually has like a slightly additional mechanism of action. So you have like this nucleus of the sperm. I don't know what it's called. The acrosome. No, it's not. I don't know. Whatever the nucleus of the sperm is called. So one of the additional effects of copper is the fact that it's actually toxic to that. So it's like a double hit. It hits lower than generally having a copper coil risk of ectopics than using like an intrauterine system. But I'm not sure about in regards to emergency contraception. I will look it up and message you, Claudia.
Oh, come on. Okay, so someone has asked, if the earliest day of ovulation is day 17, you can give the coil between day 12 and day 17. Yep, that's correct. So you can't. So basically, it's 5 days within the earliest day of ovulation. So if the earliest day of ovulation is day 12, it's 5 days after that. So you can't give it 17 plus 5. You can, if, for example, it's 5 days within the earliest day of ovulation. So if her cycle was 35 days, you could, and so the earliest day of ovulation is going to be day 21. You could give it day 21, day 22, 23, 24, 25, 26. But if that makes sense. However, if her cycle was 35 days, sorry, and she'd also had sex on day 18, under the first rule, 5 days after unprotected sex, you can give it 5 days after day 18. So you could give it on day 19, 20, 21, 22, 23, if that makes sense as well. So it's, I think I know why you're confused, because like I said earlier, so I'm trying to use different days. Does that make sense? If it doesn't, I'll try and explain again, or I'll get Nish to explain.
Again.
Has anyone got any questions? And let me know if that doesn't make sense, or I'll go over it again.
Also, while you're still here, so teaching contraception in an interesting way is very difficult.
Yeah, I'm sorry.
Like as in even all of our teaching last year on contraception is very confusing. So we talked about this, and Jess decided to do theory first and then do cases at the end, because I think that was like the most interesting way of doing it. So if you have any feedback regards to how that works, like especially, can you let us know? Sorry, could you repeat that? I'm still a bit confused with it.
Okay, so, do you want to try?
So just think about it this way. If her earliest day of ovulation is day 17, you can give her the coil at any day up to day 22, because it's 5 days post-ovulation. So you can give it at any point before the ovulation, provided how early the unprotected sexual intercourse is, or you can give it up to 22 days. So you can give it anywhere from day 1 to day 22. You can use the copper coil. Does that make sense?
Wait, let me go back to the rules.
Complicated than that, because they want you to be, remember, they want you to be safe doctors. They want you to be, a specialty year is a lot more about knowing the basics really well than knowing the niche stuff like in year 4.
And if you guys wait a second, I will post the link to that the contraindications thing I talked about. Just let me find it.
Is that the UK MEC?
Yeah.
Yeah. So yeah, absolute contraindications are really important because it comes up a lot in GP. And then just generally, like, it's very common.
Right. I'm not sure this is going to work, but hopefully it will.
Yeah, but if you have feedback, please let us know on the forum, because this is hard to do. Wow, that's big text.
I know, I'm not sure why it's come up super massive, but anyway, yeah. So I thought it was probably more useful to go through the actual, like, the theory kind of, and all of the facts, because contraception is just a lot of learning facts. Yeah, it's a bit sad, but it is. So the next thing we are going to go over is some gynae. So we're going to go over things like heavy periods, painful periods, missed periods, all that kind of thing, and then go over all the different, like, conditions that can cause them. But that's going to be like a kind of sort of presentation case-based type lecture. So
Yeah.
it'll be more interesting than this.
Yeah, so that's like more of like what we did last year. That will go back to the more traditional format. It's just like you can't really just do case-based stuff at the beginning of the year because it relies on knowing a little.
Knowing stuff.
Yeah, and I never know anything at the start of the year.
But if anyone's got any more questions, let me know. Hopefully Anush can explain things better than I have.
Yeah, with my very limited knowledge of them guys. God. Cool. Any questions? No, not yet.
Will the slides be available? I think the idea is that they were supposed to be available. Anush?
Yeah, the slides I think are online on that OneDrive link that I put on the group. Let me just check.
I've updated them, Anush. So wait, hold on. I don't know how it works.
Have you uploaded the new
I
ones?
uploaded new ones into the year 5 section.
Yesterday evening. Yeah, they're
Yeah.
up there.
Okay.
So if you go onto the OneDrive link I shared, there's a slide. There's a lecture called Contraception, and it's all on there.